Okay.
Thank you. Thank you very much for inviting me to Italy. I have never refused to come to Italy. Unfortunately, I had something to do and I have to leave after this lecture. And I wrote to Dr. Tavormina, I will come under this condition because I love Italy, I love Italians, I love Europe, and appreciate your kindness and hospitality and your kind words. Actually, I'm a very soft biological psychiatrist, which means I am a clinician who thinks biologically, but also socially and psychologically, because social factors, psychological factors, are also biological in a certain sense. They are a product of the brain. But this is not always appreciated, so I really am happy to hear Dr. Costigliolo. Is that how you say your name? Costigliolo? Costigliola. His perspective, and I congratulate you for this approach, which is something that we cannot easily do in the United States because people are too much specialized, and even GPs are specialized. You know. And I also congratulate Dr. Tavormina and Dr. Correa starting this organization and this first meeting focusing on affective disorders, which is really 85% of what psychiatrists do, and a lot of GPs deal with this subject. And it's important for private practitioners to start this movement because academic psychiatry is unrealistic in its goals. They're fighting with each other about severe disorders and their treatments, and many of them, at least in the United States, do not see patients. So I think this is a natural approach to this subject. Unfortunately, the gap between private practice and clinical psychiatry has become very wide, including in Europe, where it was much closer before, but now there's a wide gap. For this reason, I accepted to be the chairman of the private practice section of the World Psychiatric Association to fight at that level to improve the relationship between academic centers and practice of psychiatry. That is going to be my goal in the next 3 to 4 years. In the organization, we had our first symposium in Japan on this subject. So I would be happy to share our experience with you and actually make someone that you would recommend to be a member of this committee. Okay? Now, mixed states are a topic that are not well understood, even though they're extremely common in bipolar disorder. Indeed, it may be that a lot of depressions are mixed states, unrecognized mixed states. So I will first talk about the mixed manic states, which are better understood, and then share with you some recent experience about depressive mixed states and emphasize the importance of temperament in understanding these disorders. Now, this is collaboration between San Diego and European countries, and my secretary put the sign on Paris because she knows my wife is from there, but actually a lot of the collaboration has been with the Italian psychiatrists. Next one. Okay, the subject of mixed states we see in art. You probably understand this is in the language of Miró, which is Catalan. You should understand what it means, the smile of a tear. You also see it in blues music, happy blues, which is, this is in Memphis where I did much of my earlier work. So it's well known that sadness and happiness can occur together. And perhaps the best example is falling in love, which is a very excited, happy condition, but is associated with a lot of sadness, jealousy, troubles, and things like that. Indeed, much of blues music is about this problem. You know, the problem of falling in love and all the blues that it brings to you. Okay, next one. Mixed states were first described in a book that was published in 1899 by William Weygand, a student of Kraepelin, who published the book, a small book, describing mixed states. Actually, it is the only book on the subject ever published. Now, it is not exactly clear whether Kraepelin influenced him or he influenced Kraepelin, but probably, as in many situations between student and professor, there was a two-way traffic. Okay? Next one. But Kraepelin really developed the full theory about mixed states. Now, he described many types, but these are the three which are most important for us today. Now, Kraepelin suggested that mixed states occurred when mood, thinking, and activity were not in harmony. For someone with mania, there will be high activity, high thinking, and high mood. For someone with depression, there will be exactly the opposite. Low mood, the thinking is slow, and the activity is down. Mixed states occurs when the blue, which is replaces the red here. This is depressive anxious mania. Normally, you would expect high mood in mania, but in depressive anxious mania, the mood is down, the thinking is up, the activity is up. This is the manic part. In excited depression, you have the activity, which is up, but the thinking and the mood is down. And then he described depression with flight of ideas, where the thinking is up, but the mood and the activity are down. Now, much of the research has been done on the depressive anxious mania called dysphoric mania. There is relatively less research on the depressive mixed states, which are extremely important in clinical practice. And I'm going to touch on them as well. Now, mixed states were very important for Kraepelin because in his synthesis of mania and depression, mania and melancholia, as one disease, he argued that they occur in the same families, that the manic patient can get depressed, the depressed patient can get manic, but the ultimate proof were the mixed states, where elements of each disorder occurred together. So it was fundamental for Kraepelin to propose the concept of mixed states. Next one, please. Now, the next significant development occurred with the Vienna School by Berner and colleagues almost 84 years after Kraepelin. The main contribution was this concept that whatever the instability was in mixed states, it brought discordant changes in affectivity and drive. Okay? The best example of this would be someone who is depressed in mood but is sexually excited. Because in depression, the sexual drive should be down. Okay? Somebody who is depressed but has a red car and is racing. This is a recipe for suicide. Someone who is depressed in mood but is gambling. So this was a fundamental novelty that was brought by the Berner School, Vienna School. Next one. I went one step further. I said that mixed states occurred when not the drive, but the temperament is opposite to the polarity of the affective episode. Let's take dysphoric mania, for instance. This is a depressive episode in someone with a depressive temperament. Okay, this is congruent. The temperament is congruent to the depressive episode. This we will call double depression. But if mania occurred in this patient, the temperament, the depressive temperament, will change the disorder, the state of the opposite polarity, into being dysphoric. So you have an opposition between the depressive temperament and the mania. For that reason, you have mixed state. Here we have the opposite, where you have a hyperthymic temperament, and if the polarity of the episode is in the same direction, then you have pure mania. But if the episode is depressive, then the temperament, the hyperthymic temperament, will produce a different kind of depressive mixed state. This is one of Kaplan's types, actually. It is also theoretically possible that you will have a mixed temperament, like an irritable temperament, and you'll have irritable episodes. Okay? But the basic ones are the first and the last one. So you will go from drive to the temperament, arguing that the reason why there is opposition between drive and affectivity is because the drive is produced by the temperament, the opposite drive. Okay, I'll actually show you evidence for this point of view from different studies. Next one, please. Now, these are some of the emotions that you can see in bipolar mixed states. The depressive mania, the irritable mania, the anxious mania, the mixed mania, or the dysphoric mania. These are all terms used in the literature. They don't mean exactly the same thing, but they do suggest an opposition between the mania and the affective state. Next one, please. So bipolar 1 mixed state, full-blown mania with a mixed state, is a mania arising from a depressive temperament. Okay, this is the postulate. This is often called a dysphoric mania because it's an unpleasant mania. It's often associated with alcohol abuse. It is often associated with mood incongruent features. In other words, Schneiderian symptoms, for instance. And there is often confusion as a major characteristic. And they can be misdiagnosed as schizoaffective, schizophreniform, and even schizophrenic because of the confusion and mood incongruent elements. And alcohol can also produce certain psychotic symptoms in these patients. So it's important to diagnose these patients correctly as mixed states because the treatment between schizophrenia and bipolar mixed state is quite different. Next one, please. With some overlap, but it's different in the long term. Now, this is summary of a study we first did with the Italian group, which showed that if you look cross-sectionally at every patient on your unit, inpatient unit, this was a female unit, one out of three were in a mixed state. If you took history from the past, 45% of patients, almost half, had had a mixed episode. So it's an important problem. Now, only 25% had the mixed state as their first episode, 75% during later on. We also found that patients with mixed states tend to have recurrence through to type. In other words, if you had a mixed state second time, you're likely to have it the third time, maybe the fifth time, the sixth time. So there was a tendency to repeat the mixed state. Now that makes sense because if the temperament is involved, and if the temperament which is involved in producing the mixed states, then the depressive temperament will produce mixed states if you have every time you have a mania. Okay? They had fewer episodes. This is how it is different from rapid cycling. Rapid cycling actually has many episodes. Mixed states have fewer episodes, and there is more depressive than manic episodes other than the mixed states. Because not all episodes are mixed. High incidence of mood incongruent features, we found this in the Italian study. No inter-episodic social deterioration in this particular study in females. More depressive than bipolar in family history, and more likely to have depressive temperament. The proof was not full for this one. Next one. So I'll show you the most important data. This one showing more mood incongruent features in the mixed. Okay, this is just the data. This is one finding which is important. Next one. Next one. This is the other finding showing that there is, when you look at the mixed and the classical episodes, the pure episodes, that the family history for depression is much higher in the mixed form, and the family history for bipolar is much higher in the classical, suggesting, if you want to be biologically, genetically sophisticated, that the more genes you have for mania, you will have a more pure mania. And if it's mixed with the depressive genetic disposition, you will have a mixed state. Now, actually, this is compatible with modern genetic concepts, this finding here. Next one, please. We could not show that depressive temperament was involved in the mixed state, but we did show that the hyperthymic temperament was dominant in the classical one. So in this study, my main hypothesis was not shown. Next one, please. The next study was the study with Dr. Peruggi, where we could show that the temperament was significantly more often depressive in the mixed state compared to the pure manic state. And the opposite was true for the hyperthymic, which was much more prevalent in the pure mania. So we could show the opposition of temperament in the mixed state. This was a much larger study and with enough patients to be able to show. Also, we prospectively formulated this hypothesis, so we had better statistical power. Next one, please. Now, so the Peruggi study defined bipolar mixed states as patients with fewer episodes of longer duration. Patients get stuck in a mixed state, and this is very difficult for the patient because they are excited but depressed, and they are, for that reason, quite suicidal. Less inter-episodic remission, so we did not find the same thing as in the other study, which showed that they had full remission in between episodes. Psychotic depression, agitation with irritable mood rather than euphoria, pressure speech, and flight of ideas. So that depressive one mixed state was an unpleasant dysphoric condition with flight of ideas, pressured speech dominating. Next one, please. Now, this is a series of studies that I had the pleasure to conduct with French psychiatrists called the EPIMAN study. This is 105 patients in this particular study, but right now we have done 1,090 patients as well. This is the largest study of mania ever conducted, surpassing Kraepelin and everybody else, because the French wanted to be the first in the field of mania. Nobody will ever do a study like this, I'm sure. Dr. Cassidy in the United States is about maybe 300 manics. So it's called the 2000 maniaques français. That's what they like to call it. Okay. What we found in this study is that if you do a factor analysis, that activation is the major characteristic of mania, and that there are other factors which are related to the activation. Hostility, anxiety, depression, euphoria, psychosis, hypersexuality, and sometimes deficit symptoms, which includes poor judgment, incidentally. I think poor judgment is an underestimated symptom in mania, because a lot of the tragedies in mania occur in somebody who has poor judgment and who's active. Okay? They are more dangerous than schizophrenic patients for this reason. Now, what you see here is a concept that
mania could take various forms. Could be euphoric, could be hostile, could be anxious, depressive, psychotic, hypersexual. Not all manic patients are hypersexual. Okay, manic patients are not hypersexual, and could have poor judgment. That we can no longer define mania as being euphoric. This doesn't make sense anymore. Manic patients have different degrees of these different emotional states at different times. And mixed state is one of those because of anxiety, depression, hostile. But mania should not be defined as being euphoric. It's just one of the forms of mania. To say that this is classical mania and the rest are not mania is wrong. This is what the mistake in the United States was for a long time, where mania was a rare disease. Because of this, all of these are mania. Indeed, these are the worst forms of mania, being hostile and anxious, depressive, deficit, hypersexual, extremely psychotic. So mania is activation with different emotions. We actually proposed this as a way of redefining mania. Next one, please. And this is going to be in the Goodwin-Jamieson book as a major model, so it's going to dominate the new literature. Now, in the French study, we defined the depression with the Hamilton. These are two forms of the Hamilton. And we also defined it as 0 symptom, 1 symptom, 2 or 3. We wanted to test what is the threshold for defining dysphoric mania based on the McElroy criteria. Because many people think you should have full mania and full depression to diagnose mixed state, but we thought that McElroy is correct, maybe few symptoms are enough. Next one, please. The most important symptoms of mixed mania, dysphoric mania, were suicidality, thoughts of death, depressed mood, helplessness and hopelessness. Now this is, exactly the opposite of what people think of mania. And these are the most important ones, and they existed in both the probable with few symptoms and in the full as well. Next one, please. So 3 symptoms were enough. More in female. The PISA studies were done on mostly in female patients, so this was an unselected sample and showed that even in indefinite and improbable, it was more in women. There's a kind of threshold. The less the depression, the less the number of females. And there was the incorrect diagnosis. The more you go that way. Because this is recognized as mania, this is not recognized as mania. These studies, incidentally, Dr. Tavormina, were done by French clinicians. 15 clinicians from different parts of France. Okay? The new study is done by 300 French clinicians. Okay? They are people in private practice. So this is not an academic study. This is the way the reality, clinical reality is. That's why I like to work with the Europeans. Next one, please. You don't have academic center bias. Now, this is a very complicated slide, and I'm not going to dwell on it because it's a statistically complex subject. But we were testing the hypothesis, the hyperthymic and depressive. What we found was that depressive temperament was related more to the illness and the hyperthymic to gender. Now, let's go to the next and I'll show you what this means. What this means is in both men and women with hyperthymic temperament, there appears protection against depression during mania. Because men have higher rates of this temperament, the hyperthymic, pure mania is more prevalent in men. Okay? The depressive temperament in manic women seems to be a clinical marker for the well-known female inclination for depression, hence the higher prevalence of dysphoric mania in women. So this is the interpretation of the finding. It's an interaction between gender and temperament in producing mixed states, or not producing it, mixed states. Okay? Next one. Now we also suggested that dysphoric mania can be defined categorically, mania plus major depression, it's a conservative definition. Dimensionally, mania plus 2 or more depressive symptoms, 2 are enough probably. Psychometric, mania plus HEMD score above 10, and trait, you can use the MADRS if you want as well, and trait, somebody who has mania arising from a depressive temperament. The different definitions of dysphoric mania. Next one, please. A good example of temperament defining the dysphoric mania is the old psychoanalytical concept that a shy, avoidant, kind of depressive girl develops mania, explodes into mania, which is, for the psychoanalyst, a beautiful reversal. You know, how the id comes and replaces the superego or something like that. But it's a good concept because it explains why there is a reversal, you know, there. So that's an example of a depressive shy temperament going into a mania, which is going to be quite troublesome and troubling because it will be aggressive. You know, this kind of women are often very aggressive, you know. And sometimes it's mobilized by antidepressants. You treat a shy girl with SSRI and you may push them all the way into an agitated, angry mania, you know, where they would destroy everything, you know. Okay. Now, there are 1, 2, 3, 4, and ours was actually the last study, to show that 2 or more depressive symptoms are sufficient for diagnosing mixed mania. The reason this is important is that if a manic patient is suicidal, even for a short period of time, if a manic patient is crying very often, has hopelessness and guilt feeling, those kind of things, even if it's just 1 or 2 symptoms, you know, these patients do not respond to lithium, at least acutely. So that's the importance of using this lower threshold for diagnosing mixed mania. Okay, indeed, it's very difficult to find too many manics these days who do not, at least in the United States, who are not mixed at some level. You know, it's very difficult to see these patients because I don't know what happened to the good manias that we used to see in the past. We don't see them anymore. I don't know what's the situation. Do you have manics who are euphoric and singing in Italy very often? I haven't seen them in Pisa very much. Do you see them often? They're not so common. But maybe the Italian temperament is nicer. Italian temperament is nicer, so you may see more of the euphoric ones. But yes. Next one, please. Now, what are the important depressive symptoms in mixed mania? Because you cannot use agitation and sleep problems, as characteristic for mixed mania. You need specific depressive symptoms, and these are the ones: depressed mood, irritability, mood lability. It's interesting. In DSM-4 and ICD-10, irritability is a symptom of mania in adults. In children, it's a sign of depression. I don't know why they made that decision. It's wrong. In children also, it is a sign of mania. But anyway, mood lability, anhedonia, hopelessness, helplessness, suicidal ideation or attempt, guilt and fatigue. These are characteristic of the type of symptoms that would occur in a mixed dysphoric mania. Next one, please. Now, this is just hypothetical. If female mixed state is produced by a depressive temperament, you know, and there are dysphoric episodes, using tricyclics, you know, could make the episode worse. How does it happen in men? They have hyperthymic temperament more often. They have classic manias. What changes the phenomenology is alcohol and drug abuse and attention deficit hyperactivity disorder. These two are involved in changing pathoplastically the phenomenology of a nice mania in men into a mixed state. This is a model. This is not proven, but it fits the clinical experience. Next one, please. Now the bipolar to mixed state. I am going to be short on this because there isn't that much data on this. The bipolar to depressive mixed state is a depression in someone with a labile cyclothymic temperament. It manifests as a result as a stable instability. It is often associated with stimulant, you know, like cocaine and amphetamines, including caffeine abuse, typically non-psychotic. Do people abuse coffee in Italy? You drink a lot of coffee already. You know, in the United States, when I say abuse, they go and buy the pills in the stores, you know, to stay awake and you know, to feel energetic, typically non-psychotic, and often misdiagnosed as borderline or psychopathic. Next one, please. Now, this is from the first Italian study showing that the psychotic is the bipolar 1, and the bipolar 2 is unlikely to be psychotic, and they are more cyclothymic in temperament. Okay, so this was first study there. Next one, please. In 1987, we published a paper where we showed that there are some patients, depressed patients, that have been treated with antidepressants, in those days with the tricyclics, imipraminic agents, for long periods of time with negative results. They have become more aggressive, more agitated, more racing thoughts, more impulsive, especially along suicidal lines, and many of these people had sexual excitement. Now, when we first published this, people said, well, this is, Professor Akiskal is a famous psychiatrist. He sees the most difficult patients. This is a complication that is rare. And actually, it was not. Koukopoulos had described this much earlier for rapid cycling, but this was a description for a mixed state. Next one. Then Koukopoulos described it: dysphoric mood, lack of retardation, vivacious facial expression, dramatic description of suffering, spells of weeping, talkativeness, psychic and or motor agitation, restlessness, emotional lability, impulsive suicidal attempts, and high diastolic pressure. Actually, he wrote a masterpiece in 1999 with his daughter, who was also Koukopoulos, which was published in the Psychiatric Links of North America, where he says agitated depression is a mixed state. It's really a fantastic ability of a clinician to describe something. But this was the first paper. Next one, please. He also showed that antidepressants in depressive mixed states worsen the insomnia, increase the agitation, and it is associated with intense preoccupation with suicide. Next one, please. Now, this is our description with Banazzi of the bipolar 2 depressive mixed state. I don't know if you received this journal, Clinical Approaches in Bipolar Disorder. They'll send it free to you if I give you name. Is supported by a drug company, but it is completely free from the bias of the company. It is very well peer-reviewed, and it comes free now. It's beautiful colors. It's not like the usual journal that nobody wants to read. It's all statistics. This is what is essential for clinical practice, with beautiful historical figures and everything. And actually, I will send this to you, the paper, by internet, by email attachment. So you see. Anyway, we summarized our findings that the common hypomanic features intruding into MDD. See, so bipolar 2 depressive mixed state is a depression, is a major depression. But there are hypomanic features which go into the depression, such as irritability, mood lability, racing thoughts, sexual arousal, psychomotor acceleration. Okay? And these people have bipolar family history. The temperament is often cyclothymic. Under antidepressant monotherapy, they become angry, disinhibited patients. Okay? Now, this is a very important finding. Actually was described by an Persian physician who practiced in Baghdad. Since we talk a lot about Baghdad in a negative way these days, let me tell you this. His name was Ibn Sina. He was the doctor for the Caliphate, And he said, if if choleric, if the bile of the choleric type, is combined with mania, the diagnosis is no longer mania. It is melancholia. Okay? He also said that if, which is the more important statement, choleric mood occurs with the black bile, the diagnosis is no longer melancholia, but mania. So for him, angry mood was a characteristic of bipolar, even if it occurred in melancholia. This is 10 centuries ago. So I want to say, I made a slide, I'm going to send it to an Italian who is in Harvard called Dr. Fava, Maurizio Fava, the brother of the Italian Fava here, who has been publishing papers saying that the best treatment for angry depressions is SSRI. Yes, for a month, but after that, they really become very, very bad. I think he's changing his view about this being more bipolar too. But anyway, when you see anger in depression, see, the classically depressed people feel guilty. They are afraid even to ask anything from their doctor. When you see depressed people who are very demanding, angry, cursing, this kind of patient is not melancholy anymore. This is really a mixed state. And their treatment is quite different. I will give you just one clinical example of this to illustrate the importance, since all of you are clinicians here. I saw this patient in Switzerland in a very important hospital. The patient was an aristocratic woman who at the age of 67, 68 had developed a very bad depression. And she was a woman before this depression, extremely active, and she had a very nice temperament, too nice maybe, because she was very active, involved in many activities. So she develops this terrible melancholia, and they consult me because she's getting worse and worse on antidepressants. Okay? They were giving her chloromipramine, as a matter of fact. Why chloromipramine? I'm not exactly sure, but that's what they were giving her. And they thought she may be demented, or beginning dementia, because antidepressants are known to be bad for cognitive decline in the elderly. And there was one very interesting piece of information about this that also made them think that this woman is getting demented. There were medical students and young doctors, they were all male, that came to see this patient with the professor there in the hospital. And they asked her a lot of questions to this woman. She got quite irritated. She turned her back to them. She removed her skirt and dropped her panties actually, and showed her ass, sorry, I don't know how else to say this, and said, "This is my diagnosis." And she was correct. That was her diagnosis. Her diagnosis was somebody who is depressed but is quite disinhibited. Okay? And all I had to do to become very famous in this hospital is to say, just add 600 milligrams of lithium and lower the chloromipramine a little. But that's what I mean. She was disinhibited, and she was very angry. And okay, next one. I can give you 100 examples like this. So, in my opinion, lithium is not a treatment for refractory depression. Well, maybe it is, because refractory depressions are usually mixed states. That's the issue. Now, I think I want to leave this. Let's go to the next one. Okay, the long-term characteristics of mixed states are female preponderance, alcohol and neuropsychiatric comorbidity, more past depressive than manic episodes, family history more often depressive than manic, and suicide risk. This is the most important part. The suicide risk is the reason why we should make the diagnosis correctly. Next one, please. Now, there are aspects of mixed states which are not well examined. This is the type 1 mixed state for me. Depressive temperament, dysphoric mania. This is the other type, cyclothymic. You will not see it. There's a depressive episode here. Okay, a depressive episode arising from cyclothymic temperament here. I should change the color of that blue to lighter blue. Okay, The reason I made it darker blue is because it's a more severe depression, so I should make it lighter for it to be seen. Okay. There is this type also, type 3, that occurs because of antidepressants for the first time. Okay? This is iatrogenic. You know, I see this every day. Every day. There are a lot of psychiatrists, especially psychiatrists in academic settings, who think antidepressants do not produce anything bad. This is strange. Now, the reason they think this way is because they usually do not see the patient for a long period of time. The second reason is that many of them don't see patients, if at all. And the third reason is that they are usually involved in drug trials which last very short, you know. And also they eliminate anybody who would be vulnerable to, you know, they eliminate personality issues and, you know, suicidal patients, and they just study very mild depressions. Okay. The fourth type of mixed state is the one that arises from hyperthymic temperament. So these are things that need to be further studied. But these two are quite solid, bipolar type 1 and type 2. Okay, next one, please. So, the treatment implications of depressive mixed states. Inefficacy of antidepressants, if you think they are depressed. Aggravation by antidepressants. Emergence of panic attacks and severe agitation. You take a nice depressed woman and give her panic attacks, you know. High suicide risk. Need for mood stabilizers. Need for antipsychotics. And perhaps in severe cases, ECT as first-line treatment for these patients. An Italian treatment that I know is not as commonly used in Italy as it is used in the United States. Now, of the mood stabilizers, Depakote is the easiest to use. Valproic acid is quite effective for mixed states. You could use lamotrigine in severe cases, especially the bipolar 2 type, which is very unstable. Of the antipsychotics, olanzapine acts very fast. You could also use quetiapine, so Zyprexa and Seroquel. Both are sedating. You can use clozapine if they don't respond to these treatments. But the idea is that this is different than treating a regular mania or a regular depression. Depressive mixed states are refractory to antidepressants, and mixed mania is refractory to lithium. So that's the reason why they should be treated in this particular way. And the suicide risk is really the problem. And there's tremendous amount of suffering, and that's why if, you know, one day I become mixed state, you know, which is too late for me, but if I become mixed state, I would like to receive ECT personally. You know, that's what I would, because this is the way I talk with the patients, you know, who are not convinced to receive ECT. I say, if you were my mother, I will give you ECT. You know, they are not convinced. I will say, if it was me, I will take ECT. Is one way we talk about this with the patient. I really like the concept of collaboration with the patient that you are developing here. This is an extremely important one, the collaboration with the patient, to hear what the patient's wishes are about treatment. But with these patients who are severely psychotic, the collaboration model has, in the beginning, to be the doctor, you know, decides with, you know, provided that the patient can be convinced. So sometimes they have to give these treatments against the patient's will, coming with severe agitation and that kind of thing. So I think it's a model for the milder end of the spectrum in the subclinical range, let's say. You call it mental health problems. But here I think we have to use these treatments for these patients. I think this is the last one. Let me see if there's something else here. Yeah. Thank you for your very kind attention.